Hi everybody, I'm Priya Chandan. I am faculty at the University of Louisville, and today we're going to be talking about inclusive health. We do have some giveaways for you guys, which Dr. Adamkin is passing out. Feel free to come up afterwards and grab some. We've got pins, we've got these little hashtag symbols that you can take pictures with, so feel free to come on up afterwards and interact with those props. All right. This doesn't. Uh-oh. There we go. So I've introduced myself a little bit. I'm going to let the panelists introduce themselves as well, starting with Dr. Catherine Schuster.
Oh, right now? Oh, okay. I'm Catherine Schuster. Is this on? How does this work? Okay. I'm Catherine Schuster. I am Peds Rehab Physician at the University of Louisville.
You can go for it since he's still...
Hi, I'm Mary Dubon. I'm Peds Rehab and also Peds Sports Medicine at Spalding and Boston Children's.
Matt Adamkin, University of Louisville.
All right, so today we're going to be talking about several things, a wide variety of topics since PM&R is a broad field. So we're going to talk about a few cases related to pediatrics, to adult patients, as well as sports medicine, as well as transition. So getting through the disclosures, my disclosures are all related to grants. As you can see here, Adamkin the same, Schuster no disclosures, Dubon spouse employment and stock. All right, now to the actual fun stuff. So we're going to be talking about intellectual disability, and to just get everybody on the same page, we're going to go through a couple of the different definitions, because as you'll note, they vary widely. So the key thing to remember with intellectual disability is that there are impairments in intellectual functioning as well as adaptive behaviors. The age cutoff varies depending on which definition you're talking about. So AAIDD, which is the American Association on Intellectual and Developmental Disabilities, cuts it off at 18, whereas the DSM-5 states during the developmental period. And the U.S. federal law, the Developmental Disabilities Acts of 2000, says 22 years old. So that's one of the difficulties in defining this population, is that the definitions vary in terms of age, but really the impairments, those two are sort of the central things to remember when talking about patients with intellectual disability. Just like the definition varies, the estimated prevalence also varies because different people will define it a different way. So the math comes out just a little bit different depending on the definition. A good range to keep in mind is 1 to 3% of the population. This particular meta-analysis came up with 1.04. So again, I mentioned that intellectual functioning and adaptive behaviors are sort of the key things to keep in mind. So in terms of intellectual functioning, we often think about that in relation to an IQ test. So if you're thinking about it that way, it corresponds to a score of 70 to 75. In addition, the adaptive behaviors is a piece that we don't talk about as much. I think it's a little bit more quantitative and easy to say ID, it's this IQ score. But in reality, when treating these patients, the adaptive behaviors are what you really need to think about. So here, this means that there's impairments in perhaps communication, self-care, and social skills. And again, that's going to vary widely and depend on the individual patient in front of you. But I think communication often becomes sort of a big theme when working with this population, so just keep that in mind. So in terms of causes, the first point to remember is that the cause may actually be unknown. We sort of, as physicians, are very tied to diagnosis, but there's cost in doing genetic testing. And so if it's one of sort of the rarer syndromes that's the cause of ID, it may not be something that the family chooses to undergo that testing or to pay for it, because there is cost associated with it. But some of the classic diagnoses we think about are Fragile X, Down syndrome, fetal alcohol, as well as other genetic conditions, birth defects, serious head injury, stroke, or certain infections. So again, there's a lot of sort of terminology here, so we're going to go through it just to make sure everyone's on the same page. So we've talked about intellectual disability. Another term to understand is developmental disability. So you can think of it that developmental disability is the larger umbrella term, with intellectual disability being an example of a developmental disability. Other developmental disabilities would include autism spectrum disorder, ADHD, specific learning disorders, motor disorders, and communication disorders. So a particular individual could have one developmental disability. They could have more than one. They could have autism spectrum disorder and intellectual disability, or only autism spectrum disorder. So that's kind of a visual way to think about it, is developmental disability is that larger umbrella term. Another way to sort of think about it is, so neurodevelopmental disorder is another term that's used in thinking about the causes. Typically, they're sorted into environmental versus genetic causes. And then it's the neurodevelopmental disorder itself that leads to cerebrogenic conditions, which includes intellectual disability, but also sensory impairment, neuromotor dysfunction, seizure disorder, abnormal behavior, or communication difficulties. And in addition, there may be syndrome-specific conditions related to different organ systems. So the point of all of that is just to say that there are a lot of terms that overlap with each other, not exactly one-to-one, and that is a limitation when trying to do sort of research on this population, because defining the population is slightly different depending on who you are talking to. So Physiatrists Role in Inclusive Health, Caring for Patients with Intellectual Disability, is the name of the grant that AAPM&R got in conjunction with Special Olympics International. So now that we've talked about intellectual disability, I'm going to talk a little bit about inclusive health so everyone sort of understands what that refers to. So first, a little bit about Special Olympics. So when most people think of Special Olympics, they think of sports, and that is in fact true. Their overall mission is about year-round sports training and athletic competition. Importantly, it is for children and adults, and it goes down to age 8 and then up to the 80s. So just keeping that in mind, that it is sports and it is in fact across the lifespan. But in addition to sport, there's sort of 4 focus areas for Special Olympics. We're going to be concentrating mostly on health. There's a nice little brochure up here that kind of summarizes some health initiatives. I think Dr. Adamkin passed out a couple, and we've got them up here as well for your reference after. But health is where we're going to live during this talk. So Special Olympics International is actually the largest global public health organization dedicated to serving people with intellectual disability. And I mentioned that both to point out global, so it is a global organization, as well as sort of has a public health orientation. So there's several different health initiatives. Healthy Athletes was the first that started in 1997. There's a bunch of different disciplines, which you can see in the little colored circles. The orange one on the left with the stethoscope is MedFest, which we're going to get to a little bit later, so keep that one in mind. There's also the Healthy Communities Initiative, as well as Fit5, which is geared towards inclusive fitness. And most recently, there's the Inclusive Health Movement, which is the work under this grant is related to that as well. So that started about 2-3 years ago. So as I mentioned, Special Olympics Health was created in 1997, but has grown incredibly. So through Healthy Athletes, over 240,000 healthcare professionals have been trained in more than 135 countries, trained in how to serve patients with intellectual disability, how to interact with them, communicate with them, get to know them as people in addition to getting to know their health needs. They've conducted over 2.1 million health screenings. All of the health screenings data is in the Healthy Athletes database, which is the largest database on individuals with intellectual disability that exists. So a lot of the data that I'll be presenting comes from that Healthy Athletes data. And like I said, the people with ID are often sort of invisible in large data sets because identifying them becomes a little bit difficult. So the Healthy Athletes database collected through the screenings is very valuable. Also, there's initiatives that related to inclusive health, but also fitness as well as wellness, as well as policy change. So the health efforts are sort of very broad and widespread and include not just health for the athletes, but also education in terms of training providers, as well as systemic efforts at the policy level. So what is inclusive health? It's one of those terms that I think it sounds good and everyone thinks they know what it means, just sort of intuitively. But when you really get down to it, it's the inclusion of those with intellectual disability in mainstream health policies and laws, programming and services, training programs, research, and funding streams. So while there are sort of need for specialized services for some of the patients, the argument here is that the mainstream healthcare is inaccessible to those with intellectual disability. And as a result, there's negative health outcomes, there's cost, a variety of things. And so inclusion, sort of intentional inclusion, is important to make sure that people with intellectual disability are included in systems that already exist, in addition to creating sort of supplemental things, but it shouldn't be just that we're creating separate systems for people with intellectual disabilities. And in essence, inclusive health is a strategy to achieve health equity. So health equity. There's a variety of ways to talk about this. I really enjoy the quote that says, the choices we make depend on the choices we have available to us. So there's a difference between equity and equality. Equality is the same thing for everyone, whereas equity is having a variety of choices so that individual can make the choice that is best for them. So in a situation where we've achieved health equity, everyone has the opportunity to attain their highest level of health. And ultimately, health equity is the principle that underlies the discussions related to health disparities. So health disparities are essentially differences in health status between people related to social or demographic factors such as race, gender, income, and geographic region. So it's not related to their underlying health condition, it's related to other sort of social determinants of health. Another important part about health disparities, the reason we care, the reason we measure them, is it's a measure of progress towards achieving health equity. So to think about some of the health disparities that are experienced by people with intellectual disability. So in regards to sort of obesity and overweight, 45% for adults are obese, 28% are overweight, and so these numbers are higher than for the general population by about, depending on which source you look at, about 10 to 15%. And also for youth, it's sort of the same story. In fact, for youth, it's a bit more magnified. That 31.5% of obesity that we see is much higher than for youth in the general population. So other sort of specific health disparities, I highlighted some of the ones that were relevant to us as physiatrists, but 71% have identified flexibility issues, 76% have balance issues, 54% have gait abnormalities. And again, some of this is related, it's a function of access. So while you may have, as we know as physiatrists, while you may have a condition that affects your gait or affects your flexibility, with intervention that can be improved. And so the point here is that these are folks who are not getting the services they need. You can kind of see that highlighted, especially at the bottom, where 48% are in need of a new glasses prescription at the time that we screen them. And 42% have a blocked or a partially blocked ear canal. So the point of the inclusive health movement is the fact that currently people with intellectual disabilities have an inequitable opportunity for health. As I mentioned, they're at risk for negative health outcomes and health disparities due to exclusion from existing healthcare systems. And the exclusion is related to a couple things. One, inadequate access, less access to health promotion programs. So this is an important point. I mentioned in the definition of intellectual disability that adaptive behaviors are part of the impairments that you see, and communication is part of that. So very basic health messaging that we take for granted. People with intellectual disability may have not actually been told that in a way that they can comprehend. And so there's a lot of importance on sort of health promotion programs and making them accessible in terms of communication. And then sort of the determinant I'll highlight today is the lack of healthcare provider training on disability. So that's sort of a known determinant of the health disparities that we see, and so that's sort of a target for intervention. So in terms of the impact, why should we do this? At the end of the day, inclusive health promotes health equity, it does decrease costs, and improves sustainability of efforts. Having, like I said, two separate systems is just ultimately not sustainable over the long term. So integration into the mainstream healthcare system is incredibly important. So now we're going to talk a little bit about Physiatrists Role. So I'm going to turn it over to Dr. Schuster here to talk a little bit about her experience in pediatric rehabilitation medicine.
Can you guys hear me okay? All right, so I am Catherine Schuster. I did something wrong. Okay. Nope.
I think you went back.
Oh, because is it upside? Oh no. Help me. My screen went black. What happened? Okay.
The screen went black. So we'll work on it.
Except now I've completely lost the slides. Oh my gosh. I'm so sorry, you guys.
It said HDMI loss. I don't know if something was.
Dr. Chandan, did you want to go over all of this stuff about the ACGME requirements?
I can do that.
Yeah, because that's not in my slide deck.
Sure.
So we're going to switch off. Sorry.
So this is just sort of an introductory slide. Obviously, I think most of us here know what the field of PM&R is, but for those in the audience who may not, per the ACGME, this is sort of the description of the field and what physiatrists are trained to do. And so it's diagnosis, evaluation, and management of persons of all ages with physical and or cognitive impairments, disabilities, and functional limitations. So just to say that it's across the lifespan, and in addition, it's cross-disability. So not just physical disability, but cognitive as well. And so the Inclusive Health Innovation Grants, this is sort of a summary of AAPM&R's grant. And so the main focus was to improve education for residents and attending physicians regarding the care of people with IDD. And so to do that, there's sort of three main arms. One is intentional inclusion of people with ID as key patient population, which is what the panel is going to speak more about, as well as advocacy efforts and then different activities across the continuum of medical education. So importantly, other grantees were the American Academy of Pediatrics, focusing on sort of the obesity, particularly in youth that I mentioned earlier, but then sort of broadly. So this is a cross-industry effort. So you can see the JCC Association, National Fitness Foundation, the YMCA's, American Public Health Association, Public Health Accreditation Board. So again, in embarking on a journey on something like inclusive health, it takes cooperation across industries. So there's two physician professional organizations here, but also fitness and public health organizations as well. So again, intentional inclusion of people with ID is sort of what we're going to talk about. So now I will turn it over to Dr. Schuster, and hopefully I won't mess up the monitor for you in the process.
All right. If I click this way, it should be fine. Okay.
Yes, that way.
All right. And the screen is on. All right. So I'm Catherine Schuster. I did my general PM&R residency at the University of Louisville, and then I went to Texas Children's in Houston and did a 2-year fellowship there for pediatrics. And as part of that fellowship, I actually spent 2 months in the developmental pediatrics department, which was a really amazing experience in terms of shared patient populations across the spectrum of intellectual disability, physical impairments, and then combining the two. And I also spent time in the special needs clinic, so that was just children with a lot of complex medical issues, which is also a group of patients that is shared among all of those different disciplines. And now I've returned to Louisville, and I work at the University of Louisville in conjunction with Fraser Rehab as a pediatric rehab physician. So what do I do there? I do anything and everything that is related to pediatric rehab in the state of Kentucky. If anybody here would like to relocate, it would be awesome because I'm the only one. So jobs, anyone, you're welcome to come. But any referral for a pediatric patient is at minimum seen by me, and generally, so I review the referral and then I actually generally see most of the patients. So I get inpatient, outpatient referrals from primary care physicians, from neurology, from neurosurgery, from orthopedics, from rheumatology, and I also spent some time at I don't want to say it an LTAC because that I think conjures up some negative connotations, but it's a long-term care facility for children with special health care needs, and so I go there and see children there as well. So I'm sure that a lot of you guys as physiatrists have had people ask exactly what it is that you do, and everyone I think has probably developed their own kind of, this is what I say that I am, this is how I explain to my patients, my parents, whoever, about what it is that I do as a physiatrist. And so I tell people that I am the doctor who focuses on function and quality of life. I can come up with something together with you, the patient, that's going to improve your function or quality of life. And so a lot of people will say, oh, pediatrics, that's sad. And it's really not sad, especially if you're framing it in that whole mindset of you can always do something to make it better for the patient and for the families. And so that's really how I approach every patient and every patient interaction that I have. And I never know really what's going to come in my clinic door, what kind of consult I'm going to get. And so being able to see any patient with any problem with the mindset of I can always do something that's going to improve their function and quality of life. As physiatrists, we treat illness and disability, and so I think that that's really an important thing to focus on as we're seeing patients. So in terms of, to touch a little bit more on what Dr. Chandan had already talked about, some causes of intellectual disability: alterations in embryonic development, chromosomal abnormalities, exposure to drugs and toxins, environmental deprivation, problems of pregnancy, hereditary abnormalities, medical conditions of infancy, including infection, trauma, heavy metal poisoning, things like that. But that sounds like a lot of reasons that you could develop cerebral palsy, that you could be referred to a PM&R physician. And so it's really hard to separate out the two. So my role as a peds rehab doc in Kentucky, so some of the things that I try to do: adjusting your communication style and examination style for children with intellectual disability. I carry a lot of miscellaneous things in my pocket, and that's usually what can they get out of my pocket, what's in there to catch their attention. But that goes for anybody. And a lot of children with intellectual ability have overall hypotonia, and so they get sent to me because they're walking funny. And then, you're doing your examination, you're talking to the patient, and there's so many other things that you're finding that you can assist with. And so it's not just, just send them a PM&R, they need some braces. So I have 3 patient cases that I just want to go over with you guys in terms of how they ended up with me as a peds rehab doc, but how having intellectual disability doesn't really matter in the care that you provide in any way, shape, or form. So I have a young man who has a severe traumatic brain injury due to non-axial trauma in early months of life. He doesn't speak, he doesn't really have any gross motor movement, so he has spastic quadriplegic CP. But he's very interactive with the environment, and he has favorite people, and he will let you know. And so I do his Botox, and he gets very, very, very anxious. He has cortical visual impairment, so it's not that he's seeing the needle. He just is anxious that there's somebody near him with something that could hurt. And so for whatever reason, he really likes me a lot, and he sits with his arm around me with one of his hands kind of in my pocket while I'm doing the Botox. And then he's fine, and he's my favorite. Now he's going to get a back limb pump, so I won't see him as much, which is sad because I love him. I have another young man. Actually, all my cases are men, not intentional, I'm sorry. So he has a baseline intellectual disability. He has services at school. School is not his strong suit. And then he had a spontaneous AVM rupture, which is how I came to meet this young man. So he had a very large intracranial hemorrhage. And from a motor standpoint, he essentially gained back all of his function. He is 100% back to normal in terms of motor skills, but now school is even harder. So his inattentive behaviors are worsening, and his school performance has further deteriorated. And on top of all this, his mom has intellectual disability. And so how to communicate with this patient and mom how this intracranial hemorrhage, which led him to my door initially, is affecting his overall outcomes today, tomorrow, next week, next year. And so that's been a very kind of challenging ongoing conversation between myself and the patient and his mom in terms of how to continue to integrate them back into their typical environment. And lastly, so I have a nonverbal patient who required a very extensive orthopedic surgery related to, I think he had bilateral derotational osteotomies. And so he had a lot of pain post-operatively, and a lot of behavioral challenges related to pain control, but really it wasn't actually pain that ended up being the issue, is that no one was stopping to talk to the patient, talk to the family about how we could better manage these behaviors. And so it was being treated, his outbursts were being treated as pain, but that wasn't really the case. He was scared, he was frustrated, he didn't understand what was going on. And so just adjusting your treatment plan instead of just throwing medications at this young man. And then he came to inpatient rehab, and he actually did really well, and he wasn't really requiring hardly any pain medications. So how can I provide access as a rehabilitation physician? So address the child and the parents. Engage the child in whatever that they will participate in, and really providing reassurance to the parents that this is all okay. And I find that a lot of the parents feel embarrassed about the behaviors of their children, and they shouldn't. I mean, I've been hit by my own 3-year-old, and I've been hit by 3-year-olds with intellectual disability. It doesn't matter, 3-year-olds hit. So caring for children with intellectual disability, it's what we do. It's impossible, I think, to separate the intellectual disability from the physical impairment. So you can prescribe all manner of bracing and therapies and all of these things, but if the child doesn't understand and you haven't come up with a way to explain it, you're not going to get as far as if you can adjust things to their level to try to help them understand why these physical interventions are going to be necessary. And so, like I just said, adapting the physical disability as well as for the intellectual impairment. So I'm going to turn it over to my colleague, Dr. Adamkin, who's going to talk about adults. Don't touch it.
All right. So like she said, I'm gonna chat about the adult side of caring for people with ID. So a little bit about me. My name is Matt Adamkin. I trained at Carolina's Rehabilitation. I work at the University of Louisville with Dr. Chandan and Dr. Schuster at the Fraser Rehab Institute. What my practice looks like is an inpatient-outpatient mix. My inpatient side we call our medically complex rehab service. It is a hodgepodge of things from LVADs to lung transplants to some cardiopulmonary rehab, multi-traumas, amputees, strokes, whatever comes in the door. It's your kind of general rehab service. And then on the outpatient side, I have an amputee clinic. I dabble in MSK a little bit. I see my inpatients in follow-up. And I think the natural question to ask is, why am I standing in front of you guys to talk about inclusive health or caring for people with intellectual disability? Because it doesn't have a whole lot to do with any of those things I just described. So what I refer to as my side gig, or maybe my non-traditional PM&R interest, is this clinic in Louisville called the Lee Specialty Clinic. And I think maybe the case we're going to try to make today to you guys is that it should be a traditional PM&R interest. It just, unfortunately, maybe isn't. My real experience in getting an interest in this field is I have a brother-in-law with Down syndrome, and it started with me going to his Special Olympics athletic events and just being exposed to the Special Olympics, and that kind of evolved into me providing some sports coverage at some of the Special Olympics athletic events. And then that grew into me getting involved in the Healthy Athletes initiatives that Dr. Chandan was chatting about. I've been fortunate enough to be involved in a couple of residency programs where we've been able to include some of those Healthy Athletes initiatives, specifically MedFest, in the residency training. So I say all that just to make the point that I don't have any special training in taking care of people with intellectual disability. I don't have 15 years of experience working in an institution as a caregiver. There's Dr. Bachnick from Carolina's Rehab was my chair. He's sitting in the front row. He'll be the first person to tell you that there's nothing exceptional about me. I am your very run-of-the-mill general PM&R doctor. So the Lee Specialty Clinic is a multidisciplinary clinic for adults with intellectual disability. This is not an exhaustive list, but there's primary care, dentistry, neurology, psychiatry, therapy, all these things that you guys can read. And when I look at that list, and hopefully when you guys look at that list, you ask yourself what's missing. And as we're sitting here at a PM&R conference, hopefully the answer is fairly obvious. But when I was a resident at Carolinas, I actually did a 2-week away rotation at the Lee Specialty Clinic in Louisville. I was familiar with it. I wanted to see how it operated. At that point, I had started to develop my interest in this population. And then when I moved to Louisville and I took my job at University of Louisville, I called up the folks at the Lee Clinic and I said, can I just come over there and chat with you guys maybe about having a PM&R presence and see if there's any value that I can add to you. So I went over and I gave them a presentation just about what is PM&R. I think a lot of people don't have a great grasp on what we do, unfortunately. So I started talking to them about PM&R, and I said, I'd love to come out here, and for whatever amount of time you guys think would be helpful, I'll see patients if you think it'd be of value. And as I was presenting this, I was looking out across the other providers that I was speaking to, and they were just frantically, looked like they were taking notes. And then I asked them, I was like, what are you guys doing? They said, we're just writing down names of all these people that we want you to see. And as soon as we opened up this clinic spot and got the time available, my clinic booked out for about 8 months. And they started sending me emails saying, you've got to get more time out here. We need to have more clinic availability for you to come out here. And it was really not what I was expecting. This clinic has existed for several years without PM&R, and then as soon as I was there, I had a very, very full and busy clinic. So it makes me think about why that's the case, and I think you have to reflect a little bit on some common health issues that we see in people with IDD. And as you go down this list, I'm a general PM&R doctor, but I look at this list of musculoskeletal disorders, dysphagia, constipation, myofascial pain, spine disease, myelopathy, and I say, I know something about those things. I can probably help. And then you look at some common health needs in people that have intellectual disability, and in addition to the routine health management, they have therapy needs, they have vocational service needs, psychological support. And again, I look at that and I say, I know some things about that. And it makes you realize a little bit, I think we can easily forget our own expertise. I'm always having medical students rotate with me, 3rd and 4th year medical students. And one of my favorite questions to ask them is, what's the difference between PT and OT? And I think 9 times out of 10, they can't really give me a terribly satisfying answer. And it's to no fault of their own, right? We take it for granted because that is PM&R 101, is understanding some of these services and these therapists. But if this is a 3rd year medical student that's going to ultimately go be a general surgeon or an ophthalmologist, they're not interfacing with a lot of these services the way we are. And to them, PT, OT, eval, and treat is a button they click, and then something magical happens on the therapy side, and it's not of a huge amount of interest to them. So I realized that you have to appreciate that we understand these services better than a lot of other providers. So when I went out to the Lee Clinic, basically what I pitched to them is things that I could do for them is, if you have anybody with musculoskeletal issues, anybody you think needs therapy or various modalities, interventions, medications, whatever it might be, feel free to send them my way. If you'd like me to see somebody for their spasticity, I'm happy to do it. Really any functional needs you guys are identifying, or just whatever else referring providers wanted to send my way. If they had people in mind, send them to me. If I can't do anything, I will certainly let you know, but I will try. Just like Dr. Schuster mentioned, we can usually come up with something functional that will improve the quality of someone's day. And when I think about how immediately I got a lot of referrals going out to this clinic, what I realized is there was a need that was clearly identifiable but wasn't being fulfilled. I think the primary care doctors could very easily identify that the patients they were seeing had functional needs, but at the same time, they had to manage all of the medical comorbidities that primary care doctors are tasked with, and they're not nuanced in exercise prescription writing or different therapy modalities. So I think when I arrived at this clinic, I essentially just provided an outlet for that, and in that way, I think I was maybe not the missing piece of the puzzle, but maybe a missing piece of the puzzle. So I wanted to go through a few cases also. These are very quick, very easy, some patients I've seen at the Lee Clinic. So I had a patient sent to me that had chronic myofascial pain and frequent falls. I referred this person to aquatic therapy, and the patient's mother actually was brought to tears because we were trying something they hadn't tried before. They'd seen 4 or 5 different providers. The pain hadn't gone away. The falls were still happening. And what seems like a very simple intervention from my standpoint made a pretty profound difference for this patient. I had a patient with spasticity that was interfering with hygiene and ADLs. So I adjusted some medications. I referred him for botulinum toxin injections. I had a patient with Charcot-Marie tooth. I ordered some braces and referred them to therapy. Again, nothing about this is profound. I am very intentionally leaving out anything about intellectual disability in their history because it is completely irrelevant to the things I was doing for them. Whether they had intellectual disability or not, this is what I would be doing for them. And it was not really unique things based on my massive amount of experience in caring for the population that was determining the choices I was making. I saw a Special Olympics tennis player here recently who was actually a gold medal winner at the 2015 World Games, and in one of the health screening events at that event, he said he was having knee pain, and that turned out to be osteosarcoma. So he ended up undergoing a transfemoral amputation, a few rounds of chemotherapy, had a lung procedure done, and then he went back to St. Kitts and Nevis, where he lived, and there was no prosthetic care available to him. So he ended up finding his way up to Louisville through a very unique circumstance, and I saw him, I prescribed a prosthetic, and I referred him for prosthetic fitting. He will actually have his story featured, we think, on ESPN in the spring, so it's something you guys can keep an eye out for. It's a very big kind of local story when it was happening. It was cool to be a very small part of it. But again, this was nothing really remarkable that I was doing. I was seeing a person who had an amputated limb and providing the same prosthetic care I would be providing for anybody else. So when I reflect on my time at the Lee Clinic to this point, initially I was very apprehensive because I didn't feel like an expert per se. I think I had maybe some imposter syndrome where I was walking into this clinic where there's all these providers who have dedicated their life to taking care of people with intellectual disability, and I was, again, this general physiatrist, dabbling in amputee care. And what I realized is my experience was one of great collaboration. The other providers really enjoy just chatting about what I can offer, what my approach is, how it's different than some of the things that they might be thinking. And really one of great gratitude. Gratitude from the patients, from the patients' caregivers, from their family members, from the other physicians. And really what that boiled down to was I was providing access. And I asked them, why do you guys really care that I'm here? You have all these other disciplines that are in this clinic. The clinic's really an amazing place. And one of the other physicians there told me a story. So they had a patient that their primary care doctors were seeing, and they had identified some nasal polyps. So they referred this patient. They don't have an ENT physician in the Lee Clinic, so they referred this patient to an outside ear, nose, and throat doctor, and that doctor refused to see the patient and said, I don't see that type of patient. It's just not something I do. And it's incredibly unfortunate. It's very sad that story is extraordinarily common. Everybody at the Lee Clinic can tell lots of stories very similar to that, where a nasal polyp should be very, very addressable regardless of someone's IQ score. And unfortunately, because of the system that we exist in, just as Dr. Chandan mentioned, the access to care is very poor for this population, and it's a story that keeps coming up again and again. So the question is, what can we do? So Dr. Schuster got into this a little bit, and I kind of thought about, what are some ideas about how we can provide access? How can we improve the system that we're in? So I think number one is make yourself available. Something you can do is just contact your local Special Olympics Healthy Athletes programming. Dr. Chandan spelled out the very, very massive impact that Special Olympics Healthy Athletes has with the number of people coming through there. But it is still just screening. What they're doing is screening. So the question is, what happens to the athletes that they screen and they identify somebody that needs more health care, more evaluation, more workup, more treatment? So you could very easily reach out to them and just say, I am available to receive referrals when you guys pick things up in your screens. If it has something to do with a functional need or a spasticity concern or myofascial pain or back pain or myelopathy, whatever it might be, say you can send them to me. And it's not going to be 100% of your work, but it's going to be something that can really make a significant difference. I had a patient that I saw actually in my clinic at Fraser who was a Special Olympics athlete who loved bowling, and he had a stroke. And I saw him because he was having some plantar flexion spasticity. And so all he wanted to do was get back to bowling. It was the only thing he was really looking forward to. And unfortunately, because of the spasticity it developed, he was having trouble getting around. He was falling down. He didn't feel that his balance was good enough to get back to bowling. So we fit him for some bracing. We adjusted some medications. We did some botulinum toxin injections. And he came back and saw me in clinic afterwards. And he said, Dr. Adamkin, I went bowling again. And he said, and the first frame, the first ball was a strike. And you could tell, it's my favorite story. He was so happy. His mom was the happiest person I've ever seen because he got back to bowling. And there was nothing terribly unique about what I did, but again, it made a very, very big difference in his day. So in addition to the Special Olympics Healthy Athletes things you can get involved in, I would also encourage from the adult side to just think about the concept of patients transitioning from their pediatric providers. We could sit up here and talk probably for the entire weekend about transitioning from peds, and I'm not going to do that. But my point here is you have to be willing to be thinking about it. I think for the most part, these patients find their way to pediatric providers. The question is, what happens when they turn 18, 19, 20, 21 years old? You have to be intentional thinking about it. If you're in an academic setting, you should be reaching out to your pediatric providers and just be having the discussion. And you shouldn't be having that discussion on the 18th birthday. You should be having the discussion when they are 13, 14, 15 years old, introducing yourself, starting to get an idea of the management plan that's been put in place so that when it comes time for this person to stop seeing pediatric providers, it's a very smooth transition. The patient's familiar with you. The plan is one that you can continue. I had a patient I saw recently that was referred to me by a pediatric orthopedic surgeon who has spastic quadriplegic cerebral palsy and is doing great. They are 18 years old. They are not on any medications. They do not need any interventions. They've got braces that fit. Everything is wonderful. And they came and they saw me. And the patient is nonverbal, and the mom just said, I just wanted to meet somebody that I know can help if we need help somewhere down the line, just to establish the relationship. And she was terrified about what was going to happen when she turned 19 because her pediatric providers had told her, I'm not going to see you anymore after you turn 19. The pediatrician was essentially going to be signing off. She didn't have a primary care doctor. She had come across my name, so she at least could find a rehab physician, but she was needing a primary care doctor. And of course, as we all know, she had nothing to worry about because people with cerebral palsy, their spasticity resolves on their 19th birthday, so you don't really have to concern yourself with any future problems. Of course, that's not the case. Unfortunately, it is not our pediatric provider's job to follow these people through their adult life. So the adult providers really have to sort of pick up the slack there. So in caring for people with IDD, I was trying to come up with something really, wise that I could pass along to you guys, but it is the exact same. The best piece of advice I can give is just talk to them. I think maybe a lot of people who are uncomfortable or unfamiliar with taking care of patients with intellectual disability probably have the instinct to just direct their questions to caregivers or to parents, but they can provide you with plenty of information. And if you need to fill in the holes, by all means, you can seek history elsewhere. But have a conversation with your patient when you start. That's about the best advice I could probably go with. And then, again, the health issues are not anything more unique than we are used to. We are not here to treat the intellectual disability, right? Whether somebody has intellectual disability or does not, they can get back pain, they can have back problems, myofascial pain, spasticity, whatever it might be. Remember that we are the function experts in the field of medicine, and we have a lot to offer. A lot of the issues that this population might have is very much in our wheelhouse, and we are very, very capable of taking care of it. As it relates to all the health disparities that Dr. Chandan spelled out, when you start to realize that the health disparity is a consequence of our system and is not because of somebody's IQ score, you realize that if you don't do anything about that and you work in that system, you are complicit with that disparity. You can't, it's one thing to say, I'll see these patients if they come to my clinic. I've got no problem with that. That's being a very passive recipient, and I think that there's plenty of mounting evidence that because of the system, because of the poor access, because of the poor training, these patients don't find you unless you are being very intentional about taking care of them. So I think that's maybe the biggest message I can give you guys is you have to be intentional about including them in your practice. We are the missing puzzle piece, but that puzzle piece is not going to put itself in the puzzle. We have to put it there. So I think maybe that's my best message I can give you guys. And I will pass things over now for a sports-centric talk.
All right, so my name is Mary Dubon. I am trained in pediatric rehabilitation medicine and also in sports medicine. But I'm going to be wearing my sports medicine hat right now, talking about taking care of people with intellectual disabilities in the sports medicine world. Just as a little background, because I know we've all talked about like how we've gotten involved in this, I am one of those people who's been doing it for a while, but whenever you start, you're always going to feel like, am I going to do a good job? Am I going to be comfortable with this population? And the answer is usually within like minutes to hours. You realize, yes, this is awesome, and I really enjoy doing it. I started working with individuals with intellectual disability when I was 14 years old in 1999 as a camp counselor, and certainly remember being at orientation being really nervous and then having just a blast and deciding that I wanted to work with them for the rest of my life. So it's certainly something that I noticed through my medical training that, you know, you don't really get exposed to it in medical school, and then that trickles down, right? And that's probably why we're seeing that the access issues are there, is because, you know, as we're going through medical training, we're not really necessarily thinking about it as much as we should. And certainly as physiatrists, as we've talked about, it's a population that we could really serve well. So in terms of sports medicine, I like to take a step back when thinking about it to first talk about exercise. So starting with the basics, these are the current physical activity recommendations for adults. And so it includes aerobic physical activity and also muscle strengthening. So these are the recommendations for adults with disabilities. If you notice, the only thing that changed on that slide is that it says with disabilities when able, right? So it's the same exact recommendations. And I think that's important because I think sometimes we don't always necessarily think of that. Probably physiatrists think about that more than other docs do. So obviously, you know, this is, you know, in context of if there's other comorbidities or if there's physical impairments that would limit the ability to do these things, obviously you take that in mind. But whenever able, you want your individuals with physical disabilities and intellectual disabilities to have the same physical activity. What about children and adolescents? So children and adolescents should be participating in 60 minutes of physical activity daily, at least, and this should include some aerobic activity, some muscle strengthening, and bone strengthening throughout the week. So I'm sure it comes as no surprise that the only thing I changed on this slide is with disabilities and when able. So again, for children and adolescents with disabilities, it's the same recommendations. Again, obviously, if there's other comorbidities or physical impairments that will not allow for that, you make modifications. But whenever able, you want everyone to be participating in physical activity. So what do we know about physical activity participation among children and adults with intellectual disability? I was actually surprised when I looked into this a little bit more because there's a lot more question marks there than I thought there would be. I think those of us who are working in this field and familiar certainly anecdotally could say it's less than what we want, it's less than what we would recommend. But when you actually look at the evidence out there, there needs to be more epidemiologic data. It's actually been cited as an under-researched area. So I'm looking around the room, and so if anyone is interested in public health, interested in working with this population, this is a great place for physiatrists to get some work done and get some research done. Because as soon as we start proving, if there is decreased physical activity participation and why that is, we can start doing more interventions to increase it. And certainly things like Special Olympics are doing that. But from the physician role, let's start asking about it and let's start investigating that to see if we could help improve that for our patients too. So what is inclusive sports medicine? Well, in my mind, it means sports are for everyone, right? So whether you feel like you're really not good at sports, but you want to try something, or you're an elite athlete, sports are for you, right? And whether you have no disability, an intellectual disability, a physical disability, it doesn't matter. Everyone should have access to, and everyone should be able to play sports if they want to. And in that same context, sports medicine is for everyone too. So that means, in my mind, yes, physiatrists are excellent at taking care of individuals with disability, would be excellent sports medicine physicians for someone with an intellectual disability, but really any sports medicine physician should be able to take care of someone with an intellectual disability who's an athlete, right? Because it's still an athlete walking into your clinic for a sports medicine concern. And this is something definitely that I think from, because I did go through sports medicine fellowship, and it's not something that you are required to be exposed to. You need to learn about it, but it's not that, people are working with Special Olympics and things, and maybe that's something in sports medicine that we need to start doing more regularly so that people are more comfortable and familiar and are reaching out to these organizations in their practice so that the patients know who to come to if they have a concern. So I wanted to do a case. So I gave the case a name. It's a made-up case, but it just kind of goes to a point to give you a classic example of a case that you might see. So Daniella is a 14-year-old female with Down syndrome. She is here for a pre-participation physical exam, which is something that commonly, before playing sports, you will see patients that need some paperwork filled out to make sure that they are clear to participate. And that's not just for people with intellectual disabilities. We see that for kids all the time because that's part of normal practice. And they really want to participate in Special Olympics, so they just switched to high school, and their good friend is playing bocce. So they said, "Doc, I want approval for playing bocce." So you go ahead and you start your history, and you notice that Daniella, so yes, Daniella has Down syndrome, but she is really healthy and really doing quite well. She has no pain, no concerns, specifically no neck pain, no numbness, tingling, weakness, no radicular symptoms, bowel or bladder incontinence. Her gait's been fine. There's been no head tilt, nothing that you're concerned about. And again, she's never really formally exercised before, so this is really brand new to her. She has a history of a repaired VSD, but has been cleared from a cardiology standpoint for physical activity, and now is just looking to you to do the full clearance for everything else. So you go ahead and do your physical exam, and her facies are consistent with Down syndrome, and then you do a thorough musculoskeletal examination, which just shows some ligamentous laxity at elbows and knees, which is not something uncommonly seen in this population. You do a thorough neck exam, and everything looks great there too. You do a very thorough neurologic examination, and everything looks wonderful there as well. Listen to heart and lungs, and things are looking great. So again, you do a thorough physical exam, and things are perfect. So Daniella and her parents show you these 4 pages that you need to fill out. I do not expect you to be able to read this from where you are, but I just wanted you to be familiar with what these forms look like in case someone comes into your clinic looking for clearance for Special Olympics. So these are the forms that you fill out for pre-participation physical exam for Special Olympics participation. The link on the bottom of the slide includes it's the resource section of Special Olympics, and so this is where you can actually get those PDFs. And you guys either should have access to the slides now, or you will later to have our references for things like that. So I wanted to talk about atlantoaxial instability because probably some of you in the room are thinking, okay, so there's someone with Down syndrome coming in for sports participation. This is something I need to be thinking about. And I think that this is definitely like a stress point for providers, and definitely something that's been controversial over time because policies and guidelines have changed. So what is atlantoaxial instability? So it's increased mobility at the atlantoaxial joint. So if you think of C1 on C2, there's increased mobility there. And if you think about having increased mobility there, it does put you at a small but possible risk of cervical spinal cord injury. And so that's the thing that people get concerned about. Why are we talking about that? It's because in Down syndrome, we do see an increased risk of them having atlantoaxial instability. And then I'll show you later, but there's some highlighted references that I would recommend you guys reading a little bit more about atlantoaxial instability. So the reason that we're focusing on this is because, again, this is something that the policy has changed for over time, quite a few times, and may change again. It's something that the field is always growing and always evolving. So right now, for screening for atlantoaxial instability, it's a clinical screen. So you're going to be looking for history and physical examination to look for any kind of signs of any kind of cervical spinal cord compromise. So in the past, they actually did x-rays to look for if there was any signs that there could be increased movement at the atlantoaxial joint. Now, over time, they realized that those were actually not super helpful in determining. There were different cutoffs, and they weren't really sure if screening those people out from participation actually helped anything, because they've actually done studies where people who met the criteria on radiographs, they separated them into groups that participated in sports and didn't participate in sports, and a year later, they're not having symptoms. So are we really is it really necessary to be doing these x-rays? And so at this point in time, the policy for Special Olympics is that they do not need to do routine imaging, routine x-ray screening. You just look for whether or not they have signs of symptomatic atlantoaxial instability. So back to the case, Daniella had a normal exam, right? And you asked all the good questions. So what questions are you asking? You're asking all the questions that you ask anyway, right, as physiatrists. So you're doing a neurologic assessment. You know how to do a neck exam. You know how to do a thorough neurologic exam. One would argue that you know how to do the best neurologic exam to look for cervical spinal cord injury, right? So this is even more of an argument that we're great providers for this patient population. But anyway, because it's a normal exam, you're like, yeah, of course you could play bocce. This is great. Where do I sign, right? So you go ahead and you fill out her forms, and you make sure that you're counseling Daniella and her parents about what is atlantoaxial instability, what signs and symptoms do you look for, and let them know, if any of these things come up as concerns, that would be definitely something that they need to be seeking your attention immediately, or letting their coach know or something like that, because you want to make sure that you're looking out for it. And then you're going to see her in a year and reevaluate to see if she's still doing well and can participate then. So you get really inspired because you're like, I've never seen a patient for a Special Olympics screen before, and Daniella was really excited about bocce. Maybe I'll go see her. So you go to the sidelines, you see her at the event, and then you're like, this is kind of fun. Let me brush up on my knowledge of sports medicine coverage for this population because I want to start covering it. So it's not that exciting of a read because you realize, just like we've been saying, that it's just like taking care of any other population, right? So I wanted to cover the atlantoaxial instability because I think that's the one part that a lot of people feel stressed about or feel like is different than other patient populations, but pretty much the rest of it is, it's really similar to any other event coverage. As a review, Special Olympics offers athletic opportunities for novice through elite athletes, so you'd be seeing a wide spectrum of athletes. And then there's also something called unified sports, which are events that incorporate individuals with intellectual disability and individuals without intellectual disability working on a team together, which is a great inclusive opportunity as well. So sideline considerations, again, same as any other event. So emergency preparedness, right? You want to make sure that your providers know how to take care of basic emergencies. Hydration is always going to be an issue anytime you're doing a sports medicine event. Heat illness in the summer events, obviously cold illness in the winter events, things like sunscreen, pretty basic stuff that you have to be thinking about. And then obviously having how to take care of general musculoskeletal and skin concerns. So on that note, again, an under-researched area, so definitely something that we as physiatrists can be helping out, adding the research to. But what are injuries in this population? So the data out there shows it's pretty similar to other populations. This was data from the 2009 USA Special Olympics Games, and they showed that musculoskeletal and skin injuries were the most common things that people went to see the sideline providers for. There was a really low percentage of actual emergencies, and so again, it was pretty similar to any other coverage event. So the role of the sports medicine physician in caring for athletes with intellectual disability, in my mind, is similar to what we've been saying in other subspecialties, right? Advocacy is huge. So that's why I started with talking about physical activity, right? Because in order to be a sports medicine physician for someone with an intellectual disability, they need to be participating in a sport or they need to be participating in physical activity, right? So we need to actually be getting them there, and we know all the benefits of physical activity, and they deserve those benefits too. So advocating for them, working on prevention and screening. So like I was mentioning with the pre-participation physical, so getting yourself familiar with those screenings that to do, and thinking about even also prevention of things like obesity with physical activity is going to be helping too. And then sideline support and injury treatment. So again, just like taking care of any other group. So here are my references, and the ones in red are the ones on Atlantoaxial instability, and just thought I should highlight those because if this is something that you want to review, these would be some good references to start out with that.
All right, so now that you've heard a little bit from different physiatrists about their role in taking care of patients with intellectual disability, I'm going to speak to sort of the advocacy efforts and medical education efforts that have been a part of our grant activities over the last year. So in regards to advocacy, first I'm going to talk about Resolution 304 and then the AUCD HEAT sign-on letter. So Resolution 304 to the AMA was that persons with intellectual and developmental disabilities designated as a medically underserved population. So I'm going to give a thank you to the AAPM&R delegation that advocated to the AMA House of Delegates on behalf of this resolution. So the first resolved is that including people with IDD as a medically underserved population. And so this is now official policy of the AMA. The reason this is important is the medically underserved population designation is through HRSA, and it's calculated essentially with a math formula. And it's based on a couple of factors. Because people with intellectual disability are spread out geographically, because the population, as we've said, is hard to define in the first place, people with intellectual disability are actually not considered an underserved population, which I think people sort of assume that they are, and sort of have that awareness, but when it comes to policy, it is not part of the policy. So this opens up things like loan repayment for physicians, a variety of incentives related to being able to see this patient population if they had that designation. So this was a formal declaration by the AMA and a commitment to continue advocating to HRSA that this population should have that designation. The second resolved was related to medical education, so encouraging medical schools and graduate medical education programs to include IDD-related competencies and objectives in the curriculum. And so there was a previous piece of legislation through the AMA, this H90-968, that was passed in 2017. And so this was an important thing to do to sort of continue that conversation. So it brought this up to the forefront again to say, hey, we talked about this. We haven't really made much progress on it. It's still a relevant issue. So the reaffirmation there was the goal. So this, if you're interested in sort of policy, this is the policy that outlines sort of everything related to this population, but it's medical care, persons with developmental disabilities. You can see sort of in the policy timeline, this has been ongoing for some time. But importantly, AAPM&R has been able to add its voice to the conversation. So the Resolution 315 I'll talk about in a little bit, but most recently the 2018 efforts are this Resolution 304, which AAPM&R advocated for and was successful. So the AUCD HEAT sign-on letter. So AUCD is the Association of University Centers on Disabilities. AUCD is sort of the larger parent network that also oversees the UCEDs. So the UCEDs are University Centers for Excellence in Developmental Disabilities. And though they have developmental disabilities in the name, they're actually sort of cross-disability. In our great resource, there's at least one in every state, and they provide a lot of education and training. So if you feel that there's, whether that's to providers, to your residents, to students, whoever the case may be, that is their charge, and they are available to do so. So I urge you to contact the UCED in your state to talk to them about training. That is what they are designed to do. That is what they are charged to do, and they are very sort of underutilized, I think, just due to a lack of awareness. But so AUCD created the Health is for Everyone Action Team, or HEAT. And so the goal of HEAT was to build awareness of developmental disability at physician practice and training levels. So Resolution 315 came to us from the efforts of AUCD's HEAT team. And like I said, as you can see in the timeline, this was sort of feeding into AAPM&R's efforts as well. So it was sort of a united front coming at it from two different angles. One from, the folks that are sort of the disability public policy field, and then sort of the AAPM&R as the physician professional organization. And so most recently, AUCD, the HEAT team, created a letter to the LCME advocating for, the fact that despite that we know that 1 in 6 adults have developmental disability, there's currently no training requirement on developmental disability at the undergraduate medical education level. And so they wrote a letter requesting that LCME formally integrate a requirement for content on developmental disabilities into, this language here, but the official policy that governs medical schools. And so HEAT and then the undersigned organizations. And so AAPM&R, once again, was able to lend its voice to these efforts in support of this. So this was submitted to LCME in October. It will be discussed at the meeting in February. So a little bit about inclusive health. So I mentioned that this grant is through the Inclusive Health Innovation Grants. And so sort of over the year, there's been a variety of different activities, also because this is the 50th anniversary of Special Olympics. So there's been a lot of sort of advocacy and policy initiatives. There was a summit in June in Seattle, Washington, where again, AAPM&R was able to be present and represent on behalf of physiatrists. And so thinking about next steps, so currently we're working on a case statement for residency program directors that's under development. And so we mentioned sort of briefly MedFest. And so MedFest is a health screening that provides free pre-participation sports physicals to people with intellectual disability. And so we're working on a document that outlines how participation in MedFest fulfills ACGME requirements. In those ACGME requirements, there is one for residents regarding community service, and certainly this meets that. It also ties directly to each of the core competencies. I have a very sophisticated document that ties it to all the different numbers, but you can just think sort of more broadly in terms of professionalism, sort of systems-based practice. It ties directly to ACGME, the core competencies. Also, the new one that's coming out related to health disparities, this is an excellent way to fulfill that one as well, because you are working with a population and learning sort of about the health disparities that affect them. So we're working on this document. It will come out soon, and it's a collaboration between the University of Louisville and Carolina's Rehabilitation, which are both residency programs that have participated in MedFest by involving their residents. So this is a picture from a MedFest in Louisville that was 2 weeks ago, where we had Dr. Adamkin, our Associate Program Director, and one of our residents. This is a little bit about MedFest.
The purpose of MedFest is to provide a sports physical for people who want to be Special Olympics athletes.
individuals with intellectual disabilities are grossly underserved when it comes to health care. And we've got the unique ability and opportunity to have a captured audience.
The best thing is getting these kids in here and getting physicals, finding out if they need anything medically, and I'm telling you, no joke, if this wasn't here, they probably wouldn't have physicals because they just didn't have the means to get somewhere and the fear of how much it would have cost.
This event allows an athlete and a medical professional just to connect on a level that is rare.
Just getting experience and exposure to this patient population, I think, is hugely beneficial for anyone in the medical practice.
The best thing for me is just getting to interact with the athletes.
The best thing about MedFest is seeing all the smiling faces of the athletes.
It was fun. It's nice having MedFest every year.
Yes, and it helps me check, see how I'm doing, check, see how my body's going.
The MedFest is teaching us to stay healthy, be fit, be strong.
Special Olympics started as a sports organization, but it has grown in what it can do for an individual with and without intellectual disability. It's just life-changing.
So that's a little introduction to MedFest, and we can talk more about it if y'all are interested. The other sort of thing on the horizon is there will be another Inclusive Health Summit, so this will be the third iteration. At this summit, previous grantees to AAPM&R will be advising new grantees. Of note, previous grantees can apply for funding again. So if you're interested in sort of exploring that opportunity, potentially AAPM&R, AAP, I think there's a lot of work still to be done and a lot of work that we can do as physiatrists. In addition, the Center for Inclusive Health, so this website was launched. It's still sort of being populated with examples of inclusive health. There's a section that's specific for healthcare providers, and again, thanks to our relationship through this grant, we were able to contribute to it and be sort of on the front of this as physiatrists and really sort of taking ownership of this patient population and of inclusive health. So if you have questions about how to get involved in inclusive health or in MedFest, you're welcome to come talk to me about it. And also, if you're interested in medical education, there's another grant opportunity related to medical student education. It's the National Curriculum Initiative in Developmental Medicine, which I'm also the project director for this. But applications for this are currently open. So this is for engaging medical students in learning about patients with intellectual disability across the lifespan. What's unique about this is, since it's with medical students, you're really touching providers that are going to turn into surgeons, going to turn into OBGYN, into all fields of medicine. And so a lot of times these efforts really focus on sort of communication and getting to know the person. The hope is that by intervening at this level, then in the future providers will feel sort of more comfortable, more competent, and willing to see patients with intellectual disability. And also, on the AAPM&R front, now there's these member communities, and so we are planning to start one related to patients with intellectual disabilities. So if you're interested, I'll have my email at the end. Please email me. It takes like me and 9 friends, I think. We've got some friends here, so if you're interested in joining us, please do. And that's all. Thank you to... Oh yeah, so we do have the brochures as well as pins, so please don't be shy. Come grab some. If you want to take pictures with the prop, feel free. And there's the banner there, so have at it. Move around. I don't know if there's does anyone have any questions, or if you want to come up and talk one-on-one, that's fine too.